So what do we do for folks with intermediate risk? And I think, a lot of the lion's share currently comes down to the procedure, the TURBT or the transurethral resection of a bladder tumor. I showed you a short clip of what one of those looks like. So the biggest point of that is that we want to get everything completely removed at the time of surgery. So in most cases, that's going to be an anesthetic. It's going to be a tumor removal. And I do think there's a benefit to trying to use a single dose of chemotherapy in the operating room. Now, you can argue, are there some nuances to that? Like, is there a role for blue light or NBI?
That's why I just
Um,
turned my camera on.
yeah, I mean, I think that's going to be, very individualized, and that's kind of where providers and patients need to have that discussion. I use it. And the reason I use blue light cystoscopy is you'll be shocked how many very small tumors that you find that show up. And the same is true with NBI that will be there that you won't see. And it's different than carcinoma in situ where you're looking for flat lesions. These are very small papillary tumors that you just don't see them very well because they're so small. And if I see them, I'll either biopsy them or fulgurate them. Again, those change your number scores, right? Because now you're potentially looking at multifocal tumors. But my goal in that surgery is to visually clean anything out that looks like a potential bladder cancer, because I worry that they're going to come back. So anything I can do to reset the clock, in my opinion, makes sense. Now, there's randomized trial data. When you look at intermediate risk, and they compare patients who got blue light versus those who didn't, there's no difference in outcome. There's a lot of things you can talk about that study. I think there's things that contribute to that. But the way I kind of see it personally is that if someone's willing to go to sleep to have a surgery, I want to do the best surgery I can. And this makes me potentially do a better surgery. And I also think that if it's negative, that's also important, right? Because that means there's fewer things that I saw there. So I personally like enhanced cystoscopy. Many people I think AUA and IBCG recommend adjuvant chemotherapy. That's probably going to be gemcitabine at most places. So that'll be put in the bladder at the end of the operation for 2 hours. There is potential to send the cells from that. So that's a cytology if someone's had a cytology that's positive before. So TURBT, chemotherapy, maybe a role for enhanced cystoscopy. Stephanie, what do you think?
I think that makes sense. And we unfortunately, a lot of patients say my doctor doesn't have the blue light. So that seems to be a problem. We hear that from a lot of people. And I know that they're working to add blue light everywhere, but it's a
Yep.
process. It's a big deal to make a commitment to that. So it's great that you're able to use that.
And again, I don't think you need to be brand specific. NBI
Mhm.
is Olympus's enhanced cystoscopy platform. It's a flick of a
Yeah.
button. It's in many cameras. It's very good. It's shocked to me how many cameras have NBI and people don't know it. So
Yeah.
I think that's another way to do enhanced cystoscopy. I don't know
Right.
that I would move providers to find someone who has blue light, but I would say that like in general, a lot of places that take care of a lot of bladder cancer tend to have enhanced cystoscopy available to them, and we kind
Yeah.
of want,
Okay. So
yeah,
NBI is the narrow band imaging, right? So it's a
yes,
different wavelength. So it's
yep,
actually showing more of the vascularity that
that's right,
obviously tumors need a lot of blood flow. And that's
yep.
how it's showing more of under the surface. You're seeing that blood flow. And that's how you would know with the narrow band imaging.
That's exactly right. It's in the camera head.
Okay.
So one
Yeah.
of the benefits of MBI is that you don't need a catheterization ahead of time. I'll tell you that I try to always talk to folks that are going to get blue light that we're going to do a procedure. You're going to get a catheter. You need to hold it for an hour. One of the benefits of MBI ahead of time is that you don't have to do that. So, there's
Mhm.
pluses and minuses for each. Our guidelines recommend both. Um, I think, talking, providers and physicians and what they think and what matters to them. I think that's an important part of that pre-surgery discussion about what are we doing the day of and why do we do that? And, uh,
Mhm.
I always recommend people talk to their providers, right? And so everybody's on the same page.
Yep. Great. Thank you. Keep going. You're doing great. Good stuff.
All right. So this is what do we do? This is a kind of a complex table. Let me try and break this down very quick, very simply. So how often should people be getting cystoscopy, imaging, and urine tests? So very clearly for imaging, it's all over the place. I still think people need at least annual imaging. Why do I think that? Um, Really, we can have stuff show up outside the bladder. We do a good job of looking in the bladder, but we miss stuff outside of it. The only way you find that is by doing imaging. So I usually recommend annual imaging and I offer it to everybody. So again, our guidelines say 1 to 2 year intervals. That's a discussion. As far as cystoscopy, the AUA makes it very simple. They put everybody in one bucket. They say 3 months, then 3 to 6 for 2 years, then 6 to 12, 3 years, 5. So basically, it's kind of like everybody gets a scope every 3 months for 2 years, and then between years 2 and 5, it's usually every 6. So that's the AUA, and so that's probably the simplest for people to understand. Again, here we go to the IBCG. Here's your risk factors. For zero risk factors, they say 3, 9, and annually, so it's much less. If you have 1 to 2, it's 3, 6, 12, and then every 6 months. And then for more than two, it's basically back to every 3 months for 2 years. So again, we're getting to precision. There is a value in doing these risk factors for folks because again, you can escalate or de-escalate based on where people are clinically. So that's another reason why I think it makes a ton of sense. And again, this is a discussion. I've had folks say, I want a more intensive evaluation, but I don't want therapy. And I think that's fine. But again, it's really important to kind of have these discussions. Okay. I think an important thing to talk about is that first 3 months cystoscopy and why that matters so much. So overall, 6.5% of people are going to have a recurrence at that first cystoscopy. And if you're negative at that first cystoscopy, very few are going to have that at 12 months. So if you have a recurrence at that first scope at 3 months, that's almost a fivefold increase risk of progression. So that's why that first 3 month one is so important. And if it's negative, you're in a much better spot. So either way, I think that first 3 monther is really important. And again, it's really important to kind of start thinking about what's going to come down the road. Okay. All right. So therapy. So again, we're in intermediate risk. So a lot of folks are going to get treatment. In general, we recommend starting that between 2 and 6 weeks after surgery. And it's all risk-based. The AUA would say that everybody should get either chemotherapy or BCG. So with that said, at Northwestern, we have some BCG, but not a ton. So for the most part, I'm going to start most patients on chemotherapy. And if they have a recurrence on chemotherapy, then I'll escalate to BCG. That's kind of using AUA. If you sort of look at risk stratification, you could say with no risk factors, you do nothing. 1 to 2, you would consider chemotherapy, 3 or more BCG. Obviously, this is the starting point for discussion. I have a lot of folks that say, well, why can't we just do BCG? And part of that has to do with we don't have as much as we wish we did. But if we do have more than we can, it's very reasonable to talk to folks. I've had people leave our group and go to other places where is BCG, and that's perfectly acceptable. But I think kind of looking at that and realizing that there's 3 potential roads and a lot to talk about certainly lets us escalate. All right. So what do we expect for therapy? And why are both possible? Well, because the outcomes are essentially the same for intermediate risk bladder cancer. So again, these are two curves, again, starting at 100%. We get to around 50% recurrence rate at 4 years. So no real difference between BCG and chemotherapy when we look at rates of recurrence. This is a little bit of an old study. This is from 2009. Looking at more contemporary data, this is again from Dr. Kamal and I think some of the group at Rutgers looking at BCG and then gemcitabine and docetaxel. And I think this is more what you would anticipate. On therapy, the rate of recurrence is about 15 to 20% at a year and goes down to, again, around 30% at 2 years. So here's that data. Again, no real difference between these two, but I think this goes to show you that in using our most aggressive therapy, still about 20% of people on treatment are going to have experience a recurrence at 12 months. and about 30 to 35% or so by 2 years. So even with our best treatments, I would say we're falling short. And so like this is really where, some of the frustration has been up until now that we're giving you treatments that we would normally give high risk bladder cancer, and the response rates are somewhat better, but this is a much lower risk of bladder cancer. So is that really that much better? And so, I think that's where we can kind of start shifting to what's new in 2025, where we didn't have this before. Stephanie, just any thoughts from your end as far as like our treatments and frustration that you hear? Because I think that providers and pharma have kind of heard that, and that's what's led to this sort of newer group of therapies.
Yeah, I do think that because not everybody responds to BCG. And when it does work, it's great. It does, as you mentioned, it's got 6 weeks, and then you've got,
Yep.
maintenance and all the other aspects of it. So I do think that the community is welcoming some of these new options. And I'm really excited for you to be sharing that information about what's coming down the pike, what we expect to see. Hopefully approvals will be coming in the next quarter, maybe. That's very exciting.
Because when you look at this data at 12 months, I would say
Mhm.
for high risk bladder cancer, it would probably be like 5% lower. So like in high risk bladder cancer, you'd think it's about 75% at 12 months. So these are low risk cancers and they're not much better. Those confidence intervals are not that different. So I think that's what's frustrating from a provider perspective is like we go through all this decision making to say, are we going to start treatment or not? And then when we start treatment, it's not like it's like, it always goes away, right? I think that's the frustrating part is
Yeah.
that we have a lot of therapies that work about the same for high risk bladder cancer, and you would think with the risk being different that you would have better therapies.
Yeah.
So that kind of is the step to kind of like what's coming and why I'm extremely excited about this field because I think for the first time we can say I have something different to offer you.